coming to you today from my office because I want to talk about treatment options and some of the things that I've been through, and I want to make sure I get them right. They're using, the legal names for them, so if I stumble, you'll know what it is. When I was first diagnosed, we went to the primary chemical was fludarabine, brand name Fludora, and that worked quite well. I think it was like 18 months before I had a recurrence, and none of these options really solve the problem. They just move it on down the line a ways. But that was the first option, fludarabine with several other chemicals mixed in, and that worked well. When I relapsed, we tried the fludarabine and it didn't work at all. So we went into the next type of agent, which was bendamustine. Bendamustine is more targeted. Neither one of these caused baldness, and had, for me at least, limited side effects. But they worked. The second one, the bendamustine or Trianda, worked for about a year before I had a relapse. We went back to the Trianda, and with all three of or both of these, we had rituximab or Rituxan mixed in with them, which helped to speed things along. And the problem is they don't always continue to work. Just like most diseases, they tend to adapt and move into a position where they're no longer susceptible to that. So the Rituxan didn't work the last time around, so we went to something called R-CHOP. R is the Rituxan again, and CHOP is a cocktail of different drugs. It's an older treatment, and that is a relatively toxic one, and that is the result, for the baldness. You've probably seen pictures of me hairless. The hair's starting to grow back, the beard's back almost to where it was. My eyebrows are back to near normal. So that occurred fairly quickly after treatment was stopped. Unfortunately, R-CHOP didn't help at all. I know that because I have a couple of palpable nodes right about here that I can dig out, and I can feel them, so I know how big they are and whether they're going up or down in size. So all three of the major treatments have run their course. So now I'm in a position where we do something different, something experimental. We are holding another drug called ofatumumab. What a name they put on that one. It's relatively new. We're holding that one in reserve in case I need something before we get into the trial or we get into the stem cell transplant. So we're holding that in reserve. We won't use it unless we need to, because once that's gone, unless the FDA approves another oral drug, which the trials are all completed on, they're just waiting for the FDA to approve it. Unless that gets done, there's nothing else. So you see where we are, and it's a problem with most cancer patients. If they don't respond to one treatment, they can go to another and another. Eventually, you run out of options, and with CLL, there are very few. In other types of cancers, there's more than 2 or 3 or 4, and in CLL, radiation doesn't do any good either. So that's why we're down to the stem cell transplant or the trial drug. Well, the trial drug has to function in order for my disease to be reduced enough to be able to move into into the stem cell transplant. So there you have basically where we sit. Very briefly, there's a lot more to it. There's a lot you can research if you want to, but these are things that have already happened to me, and just wanted you all to know where we stand.